Welcome back to the Performance Prescription Podcast. This is where we help healthcare marketers get smarter, stay grounded, and feel seen. We are speaking with leaders in many different areas of healthcare and inviting them to share a little bit more about their view of the world, what's happening, what's on their radar screens, how they've solved problems. And today is no different. Today, we have the fortune of welcoming James Werth. James is the CEO of Tri-Area Community Health. They're located in the western part of Virginia, for those who aren't familiar. We want to talk about what innovation really looks like on the front lines of care and why learning from failure is just as important as celebrating success. So, James, without any further ado, welcome and thanks for joining us.
Thank you very much. I appreciate the invitation.
Before I ask any questions, I did want to welcome Jerry back as well as our co-host from Target Continuum. So glad to have you aboard as well.
Well, thank you. And hey, James, thanks for joining us today. And James, before I ask you any specific questions about healthcare leadership, would you be so kind as to help set the stage here and just give us a little brief introduction about yourself and the FQHC that, Tri-Area Community Health?
Sure. Thank you. So I've been CEO of Tri-Area Community Health, or Tri-Area, since June of 2019. So came in just a few months before COVID hit, which turned everything upside down, of course. I'm a psychologist by training. So prior to being at this FQHC, I was behavioral health director and Black Lung program director at another federally qualified health center and have been a faculty member. So I bring a few different experiences to this role. Tri-Area is in Southwest Virginia on the edge of Appalachia. So our entire service area is rural. We cover about 2,500 square miles. So just for sake of reference, that's about 60% the size of Rhode Island. And as a federally qualified health center, we serve all people regardless of their ability to pay. We're part of the healthcare safety net.
Excellent. Well, I'm going to jump right in, James. So when you think about leadership in an FQHC, tell me what is fundamentally different compared to other healthcare settings?
Well, most FQHCs are nonprofits. And so like other nonprofits, we have to balance mission and money, as was mentioned a little bit earlier. And on average across the country, FQHCs operate on less than a 2% margin. So we have to balance making money and helping people who otherwise wouldn't be able to receive care. Another piece of background is that FQHCs are required to have a board of directors that's at least 51% patients, which means that we're accountable to the people we serve and our communities. And the board has the exclusive power to decide to hire, retain, and fire us as a CEO. So again, we're accountable to them. I mentioned we were part of the healthcare safety net. And so our fundamental mission of FQHCs is to improve access and reduce barriers to care. And as part of that, we have to be attuned to social drivers of health in addition to medical needs. So we have to be able to help people with transportation and housing and food and employment, insurance, affordable medications, and all other aspects of their lives that may negatively affect their health and quality of life and their ability to receive care. Just a couple of other things just to round this out. Because we received some grant funding from the federal government and we have patients who are on Medicare, Medicaid, and have private insurance, and we see those who are self-pay, we are required to meet a lot of requirements at the federal level, at the state level, and at the local level. And then finally, as CEO, just as an example, we're public figures, and so we need to attend town council and county board of supervisor meetings. We have to connect and collaborate with our community partners, meet with foundations and potential donors, talk with patients and neighbors, and we have to make media appearances like we're doing today.
Yeah, no question. There's definitely a lot of moving parts in the FQHC world for sure. So, it seems like FQHCs are most definitely at the front lines of innovation. Why do you think that is?
Well, just to maybe tie back to the previous points, we have to innovate because we can't afford to be inefficient. Our resources are limited, our patients' needs are significant, and so we have to find affordable ideas that actually work. Our patients have high barriers to care, so the standard of way of doing things doesn't really work. We also have to pivot quickly because we don't have the resources to waste on outdated and inefficient processes and technology. But of course, having an innovative spirit can cut both ways. And when the ideas are solid, they make a difference. But on the other hand, trying new and untested ideas can lead to failures.
Okay. Well, yeah, speaking of failures, I myself prefer to definitely talk about my successes. So I appreciate your willingness to talk about failures, and you've written about failures in the past. So why do you feel it's important to talk about what did not work?
Well, I like to take it back to the fact that some of our greatest inventors were remarkable failures. If you consider Thomas Edison, thousands and thousands of failures with the light bulb, for example, before he succeeded. But Edison and others learned from their mistakes, their thinking evolved, and then amazing solutions resulted. And so the way that I look at it, and others too, I'm not unique in this, is that sharing failures can help people and organizations avoid reinventing the square wheel. Admitting that we got it wrong and letting others know about it can help us move on and enable the others to course correct more quickly. And then just to tie back to the theme here, organizations like FQHCs with limited time and resources don't have time and money to tread the same windy road to nowhere that others have already traveled and failed at.
Yeah. So I think, specifically, you've talked about a mobile unit. You've talked about telehealth in an EMS setting, behavioral health in private practice. Some of the things that didn't work in the past. So what went wrong? What went wrong across those efforts, and what did you learn from those things?
Yeah, I think let me start by saying that for the mobile unit, others report having been successful. So I don't want to come across as saying that mobile units can never be useful, just that we as an organization haven't figured out how to make ours work. We have lots of ideas for how it could be helpful, but we're running into barriers such as staffing, finding people who are willing to travel every day, infrastructure needs like electricity and internet access out in our rural areas, and getting people to show up for appointments. You know, just because we have the unit there doesn't mean that people will come to it. And that actually was the main thing that meant the main problem when we tried to do telehealth at an EMS setting. I still think the idea makes a lot of sense, but apparently the people we were trying to serve in the area didn't think it made sense because we had only one patient in 12 months. We had done a community meeting and people said they wanted care close, nearby. We did all the advertising we could afford other than door to door, had the local paramedics as our on-site staff who were accepted by the local community. And obviously, one person was all that came in. Our thinking about this is that we think people had their routines. And so then when they would drive to visit town, they would hold off care until they were going there anyway for groceries or for some other purpose. And then finally, in terms of these failures, I think the idea of complementing a medical practice with behavioral health care it's a well-established idea. So I don't think the idea of putting a behavioral health provider in an existing medical practice was a bad idea. I think one of the challenges was that our staff member was a tri-area staff member, not a staff member of the practice. And I don't think our staff member was integrated into the practice community. And so they would go about their day and wouldn't think about our staff member because they weren't at meetings, they weren't at lunch, those kinds of things. And they just forgot about making referrals to her.
Okay. So, James, when you sit back and you look at those past failures, what patterns, if any, do you see across all those failures? Not that you have many failures, of course. And what should other FQHC leaders avoid?
Well, I've given this quite a bit of thought, and there's a saying, build it and they will come. And I think that was the problem, is that we thought if we built it, patients would come, it would be successful. And that clearly wasn't the case with these ideas. We're still working on trying to figure out how to use the mobile unit and make it a viable option for care. But the others we've stopped. And so let's say that you were to ask me to consult with you about these ideas, the first thing that I would say is, Jerry, I think you need to do more groundwork than we did and specifically troubleshoot the kinds of problems we experienced. So what I outlined earlier in terms of some of the issues, I'd say figure out how to incentivize people to do things differently. So try to figure out what would lead that local person to be willing to receive telehealth today instead of waiting several weeks for an in-person appointment. What would help that medical provider remember to refer to a behavioral health provider, especially if they're not part of the same organization? So basically, how do you help the other people, the practice or the patients or the community members own the solution as opposed to it being our solution that we're trying to give to?
That's a common challenge for a lot of FQHCs, a misconception where, if we build it, they will come. I mean, care is so needed in the underserved communities that it's understandable, but nonetheless, it's challenging. And of course, that's where we come in, and we can certainly help in those aspects. So on the flip side, with telehealth, what is working now with telehealth, integrated care, and the school-based health centers that are working now for you, and what made those succeed for you?
Yeah, so on the flip side from what we just talked about, where we tried to build it and we thought we had some answers and missed the boat, so to speak, and on trying to fit with what the patients and the communities wanted and needed. I think that the flip side here with these is that we did our homework and we were more successful in doing that. I think there's a few themes here that I'll hit. But first, I'll say that telehealth is working for us basically because we spent the time and effort to build out robust processes, staff the telehealth program appropriately, and importantly, make it easy for staff and patients. And we've been especially successful with behavioral health appointments because they take less technology and staffing. Most, as a psychologist, I can say that most patient problems can be addressed even if the person's on video and can't be seen in person. It's a little bit different for medical appointments. What we've learned is with medical, the better the technology, the more that can be done, and therefore the more satisfied the patient and the staff are, which leads to more referrals and more willingness to use telehealth. So in that instance, it's not just building it and they will come, but it's appropriately having the appropriate staffing and the appropriate technology to make things as easy as possible so everybody is successful. And the same idea there is there with integrated care. So it's when everybody benefits. The patients have to benefit, the medical providers have to benefit, and on our side, on my side, the behavioral health providers have to feel like we're making a difference. If the workflows are problematic, if the response time is slow, or if we throw the medical providers' flow off, then there's going to be resistance to what we're doing. And the last thing that you mentioned was school-based care. We only have recently started our school-based service line. And to be honest, I've been a little bit surprised by the relatively slow uptake because everyone who uses the clinics is just raves about the in-person care and even telehealth from our main clinic to the outlying schools. Part of the challenge is paperwork and payment because we don't take payment on site. We don't want to put that on our providers. But workflows, technology, and staffing make a difference. A big difference. And probably the biggest thing that we've learned about with the schools is that it's important to have a champion in the school system, somebody who we can go to, who the schools can go to, who's that point of contact, and who is sold on the benefits of what we're trying to do.
Certainly makes a lot of sense. So, what would you say all of those successful models have in common?
I think it goes back to maybe a few of the little high points that I gave above. I'll just say laying the groundwork so that there's a champion. I'll say that even with integrated care or with telehealth, having a champion is important and somebody who's respected by the others who are being in the game, say medical providers, behavioral health providers, the school staff, parents, having appropriate staffing levels and the right people in those staff positions. Importantly, having solid workflows and processes. And then in today's world, using technology that makes the service easy to offer. So just sort of maybe going back to what's different about some of our successes versus some of our failures is really spending time and putting enough time and effort in the planning phase to anticipate these potential problems and putting systems in place to prevent them, and then do some piloting, do some proof of concept instead of throwing everything in on the initial phase. And then also being able to shift to more effective and efficient processes and activities when things don't go as planned. Got to be able to pivot.
Yeah, makes sense. So, if another FQHC leader wanted to replicate one of these models tomorrow, where should they start?
Well, I'll just assume that they've done their homework. And they believe that there's a need and a desire for the service. And as if we tie back to some of the issues with having enough money to meet our mission, assume that whatever it is that they want to do can pay for itself, or alternatively can serve as a loss leader and perhaps be worth it for non-monetary reasons such as community involvement and community support. The main thing and the initial thing and the thing throughout is staffing. From my perspective, the workforce has to be the initial and the main consideration, because unless you're going to hire more staff, there has to be a trade-off so the current staff members don't feel like this is one more burden. So, for example, telehealth, we have to make sure that we don't put a burden on that staff, on our existing staff, to do telehealth sessions and to troubleshoot telehealth connections and so forth. Without having a telehealth coordinator, all that troubleshooting would be on the clinical support staff who already have it more than enough to do.
So, you talked to me earlier about some emerging ideas that you have, like strategies that use drones. So, what role could new technologies like drones realistically play with community health?
Well, I think I really like the idea of drones. Everybody who knows me knows that I talk about drones a lot because they've been successfully used for healthcare purposes in other countries for many years. In countries in Africa and South America, they use drones all the time for rural communities. The problem in the US has been regulatory environment that makes the cost and logistics unreasonable for small organizations like us. Large retailers can use drones, but I can't afford to do everything that's necessary for drones at this point. But again, I think the usefulness, especially in rural areas, can be significant. So just for example, what I envision, if I could make it happen, is I'd like to use a drone to deliver telehealth equipment to a person's home in the morning, and then in the afternoon, have the drone return with a prescription to that patient. I could see the drone delivering an AED or snake bite antivenom in an emergency much faster than an ambulance or a first responder can get somewhere. And also internally, I could see using the drone for delivery from site to site so that we don't have to have a driver in a vehicle for internal purposes, but instead could devote those resources for patients. And just to highlight that I'm just using drones as for me, an obvious example of using technology in healthcare, but there are other types of technology. So for example, many people have satellites now for their internet, and even RVs have satellites at this point. And so the same technology could be used on a mobile unit, and then that reduces the issues related to poor connectivity in rural areas by having that satellite that was developed for another purpose, but we can adapt it over to our mobile unit options.
How do you decide which ideas are worth implementing or piloting or versus which ones might be a distraction?
Well, I can't rely on myself because I have all these ideas, and I think all of them are great. So I have to rely on my leadership team. I don't do anything without running ideas by them because they'll remind me of things I already know, but in my excitement, I tend to forget, like staffing and cost and technology limitations. And so they keep me grounded in those areas. But then they also encourage me when it seems like I've found an idea that might fill a need. And then on the flip side, if somebody brings me an idea, then I try to use the same approach to evaluate whether to give something a try or to hold off. And so for me, the key is determining whether this potential solution is going to help us be more efficient and effective, or if it might shift us away from our mission. And of course, for most things, like most things, having money to try out the new idea helps, so it doesn't feel like I'm pulling resources away from existing things that are working.
Absolutely. In the FQHC world, money always helps. So, what excites you most about where FQHC innovation is heading?
Just having this conversation and other conversations and looking in the, just headlines, there's a lot of focus on innovation right now, which means that there's a lot of people thinking about options and opportunities, which excites me because that means that we have the chance to learn from each other about what worked and, as we talked about earlier, what didn't work, and to be inspired to come up with a new idea based on what we've heard from others. So to continue to build and on each other's ideas. Guessing that you've heard the saying, necessity is the mother of invention. And over the past few years, we've seen funding priorities shift and disappear. And so we have to adapt and innovate, or we're not going to be able to continue to be here. Either us as an organization or FQHCs as an overall model won't be able to continue if we don't innovate and adapt.
Yeah, well, James, you've tried a lot of things over the years, and most definitely, most things have worked exceptionally well, and your FQHC is at a great place. But occasionally stuff doesn't work out quite as well, and you've learned. So, what advice would you have for a new CEO that's just starting out in FQHC in rural Virginia?
Well, I think that the biggest thing is you're not alone. So you don't have to figure it out all on your own. So connect and collaborate. FQHCs in general, but the CEOs in particular, but also human resources folks, chief financial officers, we support each other because we don't have to compete. So FQHCs don't compete with each other. We have our own individual service areas. And so instead of competing, we're able to collaborate with each other. And so that's the first thing is connect and collaborate. And then the second thing is as a new person, as a new CEO or new person in that role, you probably have new ideas that we haven't. The folks who have been in this role for a while may not have thought of yet because now we're thinking along sort of traditional lines perhaps. And so really want to make sure that new folks feel like we value their insights and their brainstorms, their ideas, because again, everybody can learn from sharing with each other.
James, I've really appreciated and enjoyed our conversation today.
I appreciate you both and tons of insights, and thanks for giving us a glimpse into uh, what it's like and some of the challenges. I appreciate being able to touch on successes and failures and acknowledge that that's just part of the journey here. But we want to wish you the best as you move forward and keep trying new things. And thanks for everything you're doing.
Thanks very much. Appreciate the opportunity.